Good afternoon, everyone. Today, I'll be presenting a paper on factors influencing corneal haze post-collagen cross-linking in keratoconus treatment. This is my financial disclosure. So, as we all know, keratoconus is a progressive corneal associated with corneal protrusion and thinning that leads to irregular myopic astigmatism. It is usually bilateral but asymmetric, presenting to us with mostly during the second and third decade. And for mild to moderate keratoconus cases, we usually prefer doing collagen cross-linking using riboflavin and UVA light. The most common complication post-collagen cross-linking is corneal haze formation that leads to increased backward scattering of light, increased corneal densitometry, which also leads to temporary suboptimal visual acuity. Now, about corneal haze post-cross-linking, we can assess this qualitatively using slit lamp biomicroscope, confocal microscopy, as well as anterior segment ASOCT. Quantitatively, it can be assessed using sign plug photography. In few studies, they have shown using in vivo confocal microscopy that there is increase in the density of extracellular fibrillar matrix. Also, there is reduction in the density of anterior keratocytes, which leads to the hyperreflective phenomenon in the treated zone. In pentacam, corneal densitometry is analyzed using first the machine locates the corneal apex, and then it analyzes an area around the diameter of 12 mm, which is further subdivided into 4 zones that are central 2 mm, 2 to 6 mm, 6 to 10 mm, and then 10 to 12 mm respectively. And the output is given in terms of gray scale unit, which measures the minimum light scatter and values it as 0. That is the maximum transparency, and maximum light scatter leveling it as 100, which suggests minimum transparency. So the main objective, the primary objective of our study was to determine the factor influencing corneal haze formation following C3R, also to address the association of pachymetry, keratometry and their changes associated with haze formation. Secondary objective was to analyze the relationship between corneal haze and visual outcome. So this was a prospective observational study which was done over a period of 24 months that include 84 keratoconic eye. Pre-operative assessment was done by measurement of uncorrected and best corrected visual acuity, slit lamp examination, and then pentacam was done to measure the K1, K2, Kmax, K-mean, central corneal thickness, thinnest point, densitometry values, ART max and progression index. And then patients underwent the cross-linking procedure, and post-procedure visual acuity was again measured, the uncorrected best corrected, with slit lamp examination for measurement of corneal haze and its grading. Follow-up visit was done in 1, 3, 6 and 12 months respectively, and all the factors were reassessed. So coming to the results, the mean age in our study was around 19 years and 8 months. Majority that belonged to the age group of 16 to 20 years, followed by 21 to 25 years. In our study, there were 48 females and 36 males. The mean baseline UCVA improved by one Snellen line at the end of 1 month, plateaued over 3 months, further improved at the 6 months, and then plateaued. The mean baseline BCVA remained unchanged. Coming to the K-mean and K-max reading, which peaked at 1 month post CXCL with subsequent dip, and the thinnest corneal thickness largely reduced until the first 3 months, yet showing an increased trend from the 6 month onwards. Based on slit lamp grading of corneal haze at 1 month, nearly 98% of the patient had grade 1 haze, which remained relatively stable at the end of 3 months and 6 months. By the end of 1 year, nearly 53% had complete resolution of haze. Coming to ART max, at 1 month median ART max decreased to 116 when compared with the baseline value of 174. At 3 months, it further decreased to 101. At 6 months and 12 months, it progressively increased to median value of 120 and 137 respectively, and all these changes were statistically significant with a p-value of less than 0.01%. Now, association of anterior layer thickness, densitometry values, there was significant association in all 1 month, 3 months, 6 months and 12 months. In central layer densitometry, compared to the baseline, the changes were seen in every layer, every zone except for the 6 to 10 mm zone. In case of posterior layer, significant changes were seen except for 6 to 10 mm zone in 6 and 12 months. So the main discussion from the study that we got is K-mean and K-max reading had similar pattern that peaked at 1 month. The increase in Kmax value 1 to 3 months after CXCL was attributed to disorganized stroma. In contrast with the other studies, our studies show a significant change in densitometry values, especially in the anterior layer of the cornea that peaked at 1 month. So based on the existing literature, most common influencing factor listed for the development of haze include pre-op Kmax, thinnest corneal thickness, and young age of the patient. And in our study, pre-operative ART max had significant association with persistence at 6 months. The strength of our study was, this was the first cross-sectional study done in South India in patient undergoing C3 or post-keratoconus. It is an objective and reliable method that we use was pentacam to assess corneal densitometry. Also, our study may help us to predict the treatment success and expectations post C3R. The limitation was that the period was just 1 year, so we cannot exclude the possibility that the corneal haze might continue to evolve beyond the time frame. There was no comparison or control group. Densitometry measurements with sign plug camera has its own limitation. These are my references. Thank you.
When you measured the haze, you found that it was increasing or stable? You said it's stable.
Yes, ma'am.
But you said it might evolve, you said in the last slide.
What we measured, ma'am, in 84 keratoconus size, mostly patient has had grade 1 haze by the end of 3 months.
So what functional disability did it create? Was there glare? Was there was diminution of vision?
There was diminution of vision, ma'am.
Did you check glare and other functional visual disability?
No, ma'am. We just checked the uncorrected and best vision.
How much line difference was there?
There was 1 Snellen line of difference, ma'am, which was found in 1 month, which plateaued over a period of 3 months. Then again at 6 months, there was difference of 1 Snellen line, which again plateaued at the end of 1 year, ma'am. Sir, mostly in our study, we saw the apical keratoconus more in our patients. And other ocular conditions, sir, VKC is the most common ocular condition that is associated with what we see in associated with keratoconus. That's true. Marfans, yes, sir. Down syndrome. Yes, sir.
What are the indications of collagen cross-linking in keratoconus? At what stage you will do keratoconus?
Ma'am, whenever we see any progression in the patient which previously has presented, we have done pentacam and we see progression. Also, if the patient present to us in a certain age group, we usually don't see progression beyond the age of around 26 to 30 years. So when the patient present to us in the age where we expect progression, we usually take them up for collagen cross-linking. Also, when there are obvious parameters in the pentacam which are showing that the patient is keratoconic, then we usually take them up.
What are the contraindications?
Sir. Okay, sir. Got it. Okay, sir.